Welcome to committee. We have people throwing candy. No, welcome to committee. Can you hear me? I'd like to welcome everyone here, the members, staff members, and those that are here for conferees and guests, and those online. And we will start today with a hearing on House Bill 2676, permitting a pharmacist to initiate therapy for certain conditions consistent with pharmacist education, training, and experience. The revisor will give us an overview. Carly, before you start, I just want to welcome our baby member today, Representative Kyle Hoffman. Thank you. Oh, and we have Representative Cindy Howerton. Okay, thank you. Thank you, Carly.
Thank you, Mr. Chair. Committee, House Bill 2676, as introduced, permits a pharmacist to initiate therapy for certain conditions consistent with the pharmacist's education, training, and experience. Subsection A1 allows a pharmacist to initiate therapy if such condition does not require a new diagnosis, is minor and generally self-limiting, has a test that is used to guide diagnosis or clinical decision-making, or, in the professional judgment of the pharmacist, constitutes a patient emergency. Subsection A2 requires a pharmacist to determine if a specific act is within the scope of practice of a pharmacist. The pharmacist shall determine if an act is expressly prohibited by the Pharmacy Act of Kansas or another law, consistent with the pharmacist's education, training, and experience, and within the accepted standard of care that would be provided in a similar setting. Subsection E states that the amendments to the section shall be known as the Pharmacist Practice Authority Act. House Bill 2676, as introduced, would take effect upon publication in the statute book. It can stand for, take effect upon publication in the Kansas Register.
Very good. Thank you, Carly. Are there any questions for the revisor? Representative Oropeza.
Thank you for your brief. So was this something that will be worked out by the Board of Pharmacy as to what conditions will be treated?
Mr. Chair, Representative, the bill does not mention the Board of Pharmacy. So
it's just
it does leave it up to the discretion of the pharmacist, provided with the subsections below, like is it expressly prohibited by the Pharmacist Act and so on and so forth.
Okay, all right, thank you.
Any other questions for the revisor? I have just one quick question. Part of I believe in the bill it says something about, you mentioned it, it would be a pre-existing diagnosis or not diagnosing, but yet in some of what I've heard, it is test, diagnose, and treat. Could you kind of give some definition on whether the pharmacist will actually be diagnosing? Thank you.
Thank you, Mr. Chair. The bill in line 13 says that notwithstanding the subsections of B through D, does not require a new diagnosis. So that's the only language that speaks to that in the bill.
So according to the bill, they would not be making a new diagnosis. They would not be allowed to make a new diagnosis then.
Correct.
Okay, thank you. Any other questions? Thank you very much. First on the proponents, we have Mr. Tim Frost, Senior Fellow, Cicero Action. Thank you, sir. Welcome to committee.
Thank you, Vice Chair, Chairman, and committee. For the record, my name is Tim Frost. I'm a licensed pharmacist and Senior Fellow with Cicero Action. We're a nonprofit focused on policy solutions for patient access and innovation in healthcare. Previously, I served as the Chief of Staff for the Idaho Attorney General. Prior to that, I was the Deputy Administrator at the Idaho Division of Occupational and Professional Licenses, where I oversaw the Board of Pharmacy, the Board of Medicine, and the Board of Nursing. House Bill 2676 reflects a policy direction that Kansas would not be the first to take. A standard of care approach to pharmacist practice has already been implemented in Idaho, Colorado, Montana, and Iowa with a strong safety profile. Similar legislation is also being introduced in more than 10 states this year, reflecting a growing national trend around this model. The need for action in Kansas is not hypothetical. By 2030, the state is projected to face a shortage of more than 2,100 physicians, more than 250 primary care providers included in that shortage. Today, 71 of Kansas' 105 counties are currently declared as professional shortage areas for primary care. Patients are waiting weeks or months for appointments or going without care entirely. At the same time, Kansas already has a highly trained healthcare workforce embedded in nearly every community, licensed pharmacists. Community pharmacies are open nights, often weekends, do not require patient appointments, and are often the most accessible healthcare site in your community. When care is delayed, conditions often worsen and costs rise. Timely entry into care matters for both patient access as well as patient safety. This bill regulates pharmacist practice under a standard of care framework, the same accountability model that Kansas already utilizes for physicians, nurse practitioners, and physician assistants. Pharmacists must practice within their education, training, and experience and remain fully accountable to the licensing board, malpractice standards, and the courts in Kansas. This is not deregulation. This is outcome-based oversight. That oversight does work in practice. Idaho, after 8 years of implementation, there have been 0 patient complaints. There has been 0 physician complaints. There has been 0 final disciplinary actions on a pharmacist based on the prescribing services that they've provided. And there has been no increase in professional liability insurance. The same strong safety profile is seen across other early adopter states as well. But I think maybe most importantly, pharmacists are trained for this role. All pharmacists complete a doctorate of pharmacy, PharmD degree, from a program accredited by the Accreditation Council of Pharmacy Education and are licensed at the state level. That education includes a minimum of 1,740 patient clinical hours encompassing patient assessment, diagnostic reasoning, medication administration, and prescribing. This bill does not expand education, and it does not lower the community standard of care in Kansas. It aligns Kansas law how pharmacists are already trained, licensed, and held accountable. The approach also aligns with federal healthcare policy. The Centers for Medicare and Medicaid Services Administrator, Dr. Oz, who's a cardiologist, has publicly identified pharmacist prescribing as a practical solution to primary care shortages happening in our country and happening in Kansas. CMS has reinforced this effort through the Rural Health Transformation Program, which rewards states that modernize their pharmacy practice authority to align with what this bill has before you today. This bill positions Kansas to remain competitive for that federal innovation and the rural health funding. Perhaps most importantly, this bill doesn't require a new funding mechanism. Kansas does not need to build new clinics. We don't have to wait a decade to train new providers. This capacity and access exist in our communities today from a doctorate-trained pharmacist provider. The bill is measured, it's evidence-based, it's consistent with how other states have regulated pharmacists and approached this. Thank you for your time today. I'd be happy to stand for questions.
Thank you, Mr. Frost. I'm sorry I botched your name when you came up. Are there any questions for the conferee? Yes, Representative Ruiz.
Hi, thank you for your testimony. You mentioned that there are other states who are looking at the same type of bill. Can you name a couple of them? I'm going through. Never mind. I just saw them on your testimony. Is it also because Cicero Institute is pushing for this and going state to state?
Chairman and Representative Ruiz. So certainly there's multiple national think tanks that are supportive of this policy. I could highlight the Cicero Institute, the American Legislative Exchange Council, the Cato Institute, West Virginia Knee Center, George Mason Mercatus Center. All of those are supporters of this policy. I think more broadly, the reason why there's a significant momentum across the states is because CMS, specifically related to the Big Beautiful Bill and the creation of the Rural Health Transformation Program, it created an incentive over the next 5 years for $50 billion to go to the states over a 5-year period. In doing that, CMS created state scoring mechanisms for each of the state and rewarded states based off of what their current policy mechanisms are. They specifically included one of the gaps across the country is not utilizing pharmacists to their full extent of education, training, and experience. And so I think that's where we're seeing states from all directions across the country looking at this policy.
Thank you.
Thank you. Representative Bueller.
Thank you, Mr. Chair, and thanks for being here. It was a committee meeting a week or so ago. We talked about the PrEP Act of 2021, where pharmacists' ability to do things like COVID, UTIs, strep screens, and things like that were already put into practice at the federal level. Has that been in any way, has it in any way shaped or advanced the outcome of this? And then I do have a second part of the question, if I can follow up with it, a little bit unrelated, but I'm just curious, because it feels like in some regards, if we don't do things like that, we're actually moving backwards. I don't know if you had a perspective on that.
Vice Chairman and Representative Bueller, thank you for the question. So it pertains to the PrEP Act. So yes, this bill directly builds upon that on a state level. The reality is there were a few states that the legislature had already approached and addressed pharmacists' authority to be able to utilize a CLIA waive test and then determine based on the results of that test the ability to treat respiratory viruses such as COVID-19. But the vast majority of states had a state scope of practice prohibition that was already in place. And so the federal government through the PrEP Act had to come in, essentially create a state level preemption on scope of practice laws. And I think, from my perspective, from maybe a little bit of a state sovereignty piece, I think it's much more important that the state legislature make a determination of what is authorized for healthcare providers to do or not do. And I think this bill provides a safe mechanism for you to have a test and treat process based off of CLIA waive tests.
So you mentioned the Rural Health Transformation Program, and I know that Kansas has been awarded $221 million. What I don't know is, I haven't seen the complete list, but are there penalties for non-compliance, or is it merely if you're awarded a grant for something and you don't perform, then you lose that grant? I don't know if you have any fidelity on that or not.
Vice Chairman and Representative Bueller, so my knowledge is the states had a scoring framework by which they were evaluated on their current laws related to pharmacist prescribing as one mechanism for them to review. It's not clear, and then there's been an award from the federal government that specifies what the funding is going to look like for the next 5 years. We've not seen any written guidance yet to CMS what enforcement is going to look like as it relates to that funding, and whether or not CMS is going to change some of the funding mechanisms based on whether or not state will change some of the policy levers. So to be determined.
Okay. Thank you, Mr. Chair.
Thank you. Any further questions? Representative Oropeza. Oh, I'm
Thank
sorry.
you.
Representative Droege was ahead of you. I'm sorry. Representative Droege, then Oropeza.
Thank you, Mr. Chairman, and thank you for your presentation. I'm curious, what is your vision here? What are we talking, exam rooms and lab work, and then further with maybe, probably the next step would be swab testing and maybe request x-rays and MRIs and diagnosis, and it seems like that's kind of the camel's nose under the edge of the tent here. Am I missing something?
Chairman and Representative Droege, thank you for the question. So the starting point of this bill in Kansas actually isn't quite as far as some other states are already. So in Idaho and Iowa, all those things you just mentioned are authorized by pharmacists and have been authorized for the last 8 years. That wasn't the starting point of this legislation. So the starting point was actually a framework does not require a new diagnosis. So scenarios that maybe are preventative health and there's not an actual need for diagnosis. You could think of epinephrine, naloxone, smoking cessation. Those aren't diagnostic in nature. The diagnosis provision is incredibly limited in this bill because it's limited to based on the results of a CLIA waive test. And so CLIA was a federal law that passed in 1988, and there's different levels of testing authority from waived, moderate, and high complexity. This bill only authorizes test and treat based off of waived testing. And those waived testing are already available to the public over the counter. In other words, these are tests so safe that FDA authorizes patients to do it themselves. So it's the limited authority would be if clinical guidelines and standard of care in Kansas authorize a waived test as the basis for determining appropriate diagnosis for limited conditions, this bill would authorize a pharmacist to test and treat in those scenarios. It would not authorize a test and treat based on a laboratory test beyond a CLIA waive test into some of the things that you had talked about, like a blood chem panel and MRIs and things like that.
Thank you.
Thank you, Representative Oropeza.
Thank you, Mr. Chair, and thank you for being here. I was actually with Representative Droege. Can you give us an example of what this is actually going to do?
Chairman and Representative Oropeza, thank you for the question. So if we look at the bill, you've got essentially 4 categorizing scenarios. Does not require a new diagnosis, is minor, generally self-limiting, based on the results of a CLIA waive test or an emergency. So I'll kind of go a little bit line by line on those. Does not require a new diagnosis. Those are scenarios where it's preventative health. That could be immunizations, it could be naloxone, it could be epinephrine, for example. Scenarios where patients don't require a diagnosis but need critical access to those drugs. Patient emergencies, for example, in subsection D could be like glucagon, emergency refills, situations where a patient doesn't have immediate access and they've run out of refills. A pharmacist would be able to prescribe based off of standard of care to provide a patient that. Guided by the results of a CLIA waive test would be the test and treat scenarios for like respiratory viruses. So flu, strep, COVID-19, those are scenarios that fall underneath that. And then the minor, generally self-limiting would be mostly what you would see of cold sores or Lyme disease prophylaxis, hair loss, simple things that patients are often treating over-the-counter medications already, but there are a few prescription products that would better treat them that a pharmacist would be able to then initiate a prescription for. So the vast majority of what falls within here is a very limited, low-risk situation.
Okay, thank you.
Thank you, Representative McDonald.
Thank you, Mr. Chair. I was trying to look at the fiscal note here, and the board didn't really give a fiscal note. They did indicate that this could cause more oversight. In the previous states that this has passed in, was there an increase in complaints, investigations, disciplinary actions, that sort of thing, or do you have that information today?
Chairman and Representative McDonald, thank you for the question. In the states that it's passed so far, we have not seen increases in patient complaints. We haven't seen increases in physician complaints. And so therefore it has not predicated in a way that has created a lot of investigative need or new need for resources. I'll leave that question as it relates to the Board of Pharmacy on how they want to address it, but I think you should expect a narrow authority that's being offered here on initial implementation over the first number of years. I think that's very low need of needing new FDE.
Thank you, Representative Turner.
Thank you, Mr. Chair. So I was just trying to get my arms around this also. So it talks about initiating therapy, and it seems like there's a lot of discretion here for the pharmacist. I mean, you talk about it's a limited low risk, that it's consistent with education, it's professional judgment, it's within the scope of practice. Those are all within their discretion to make those decisions. And then you've also mentioned that they determine if a new diagnosis is needed. So that check is also up to their discretion. So where is the check, I guess, on what they decide in all of these things for, you follow me? I mean, it seems like the rules are pretty wide open for them.
Chairman and Representative Turner, thank you for the question. So I would say the key accountability measure in this bill is incredibly similar to what you would see within the Medical Practice Act under their unprofessional conduct and their disciplinary authority. It anchors things to the community standard of care. In other words, what would a reasonable and prudent individual in that community in a similar situation or setting make that decision? That's the limit under the law. And so In a complaint situation, the board would have the full ability to review that complaint, to determine was there a violation of the Kansas Community Standard of Care, and then have the ability to revoke a license, suspend the license, fine, provide a warning. All of those elements are within the standard of care provision of this bill.
Follow up. And all of those would be triggered, like you said, by a complaint or by some adverse outcome that would trigger that, correct? And then the last thing I thought I heard you say, pharmacists will be able to prescribe, or so basically they can prescribe drugs under this, correct?
Yes. Chairman and Representative Turner, that's correct. Yes. The authority to prescribe and initiate a prescription is limited to those 4 categories of subsection A through D.
All right, thank you.
Thank you, Representative Ellis.
Thank you, Mr. Chairman. I understand that you can refill emergency prescriptions and over-the-counter. I just want to, what about antibiotics and thyroid medicine and blood pressure medicine and diabetes and steroids for poison ivy? There's a large span of their, what about those items?
Chairman and
And
Representative
I really want specifics, like what can you do and what, you know, because our pharmacists are great in my county. They're wonderful people. But I really want to know specifically what they can't do.
Chairman and Representative Ellis, so under the framework of this bill, the diagnostic authority for a pharmacist is limited to a CLIA waive test or a condition that is minor or generally self-limiting. So for example, you detailed things like antibiotics. If clinical guidelines in the community standard of care would allow a pharmacist to test utilizing a CLIA waive test and then treat based off of that and is appropriate to provide an antibiotic, they would have the limited authority to do that. If it falls outside of that, they do not have the diagnostic authority. So you mentioned some scenarios like blood pressure, diabetes, chronic care conditions. This bill does not authorize a pharmacist to diagnose those conditions.
Steroids for poison ivy, you know, this, they come out with 7, 6, 5, 4, 2, 1. What about that? Prescribing steroids, tablets.
Chairman and Representative Ellis, I think most of the scenarios of prescribing steroids in that type of scenario would not be a minor or generally self-limiting and would fall to a primary care provider to be able to diagnose. So I don't believe the bill would go that far, in my opinion.
Thank you, Mr. Chairman.
Thank you, Representative Berquist.
I think I got my answer. Thank you, Mr. Chair.
Representative Droege for the second time.
Thank you, Mr. Chairman. I guess this is just a little bit different track, but what about veterinary medicine? We've got routine things coming in for pets. Is a pharmacist going to start taking care of that too?
Chairman and Representative Droege, thank you for the questions. The practice of pharmacy is limited to human patient care and would not fall to the practice of veterinary care, so pharmacists would not have any authority to prescribe for animals. The board is here if you'd like to verify that.
I routinely, throughout my 40-year career, the pharmacist filled scripts for me multiple times, and there were minor things like, say, amoxicillin for a urinary tract infection or something for an ear problem or eye, ointments for an eye. But so I think that there's a script there also. Thank you.
Chairman, could I clarify?
Sure.
Thank you. Chairman and Representative Droege, I'll make a distinction here. This bill does not address pharmacists' current dispensing authority. So if a valid prescription comes from a licensed veterinarian based off of your clinical expertise and you determine, that's needed for that particular animal, this bill doesn't change the current law as it relates to pharmacists dispensing of that drug. All I was simply saying is the bill does not authorize a pharmacist to initiate a new prescription, the prescribing authority for veterinary care.
Thank you. Any other questions? I just have one quick one. I'm a little confused. When we heard earlier about the bill, it was no new diagnosis would be made authorized by this piece of legislation. But yet your examples, some of them do require a new diagnosis. Even smoking cessation, there's a is a diagnosis of tobacco addiction. Maybe hypoglycemia, you're talking about glucagon. It's a diagnosis. And so I think part of the problem and part of why it seems like a moving goalpost to some of us is there's not a clear understanding of what diagnosis means. And maybe if you would be able to, maybe you could give your understanding of what diagnosis would mean in this setting so we could know a little better what the limitations are. Thank you.
Chairman and committee members, thank you for the question. So how I would, approach how the reviser stated this bill versus how it would put in front of you. You've got 4 categories that we're authorizing pharmacists to prescribe under. One is does not require a new diagnosis. That word new being very critical there. So a scenario where a qualified provider has provided a diagnosis, like that piece does not change. So it doesn't authorize under that provision of subsection A, pharmacists to create new diagnosis. Subsection B details scenarios that are minor or generally self-limiting. So those are scenarios where patients already know what their minor ailment is. That is so in that scenario, you're authorizing pharmacists limited diagnosis authority over a minor and generally self-limiting scenario. Subsection C details the authority to diagnose based on the results of a CLIA-waived test. That is limited authority for diagnosis based off of CLIA-waived tests that are determined federally by the CLIA amendments of 1988. So you have 2 scenarios here where there's limited diagnosis authorized to a pharmacist in this bill. Minor and generally self-limiting scenarios and scenarios that are guided by the results of a CLIA-waived test. Anything that falls outside of that scenario would be a situation where another qualified healthcare provider would have to determine that diagnosis, and a pharmacist cannot prescribe. They would have to get an appropriate referral from a physician or other diagnosing prescriber.
Thank you. Any other questions? Thank you for your testimony. Appreciate
Thank you.
it. Next on the proponents, we have Alexandra Blasi from Kansas Board of Pharmacy. Welcome to committee.
Thank you, Mr. Vice Chair, members of the committee. It's so nice to be with you today. I am Alexandra Blasi. I'm the Executive Director of the Kansas State Board of Pharmacy. I've been in that role for about 10 years, and I'm pleased to provide this testimony on their behalf in support of House Bill 2676. The bill would expand, as you know, the practice of pharmacy to allow pharmacists to practice to the full extent of their clinical training and expertise as healthcare providers. Already, a number of you have raised questions about how the board operates and how the board would implement this. And so, since you have my written testimony, I'd love to focus a few more on the ideas and points that you've already hit upon. First of all, I want to note that pharmacists have been taking, I think, baby steps toward utilizing some of their additional training and experience in Kansas for a little while, pursuant to this body's direction. That has included expanded immunization authority for pharmacists and pharmacy technicians, the point of care testing and treatment protocols that were initiated a couple of years ago, and that include UTI, strep, and influenza, both for adult and pediatric patients. And then in addition to that, the Kansas Pharmacy Practice Act includes something called collaborative drug therapy management. And that is actually something that's done in conjunction between the pharmacist and the practitioner to determine the best course of treatment for a patient. One of the significant limitations, because we get this question all the time at the Board of Pharmacy, what are the limitations of using collaborative practice authority between the physicians and the pharmacists? And my answer to that is always that it is a one-to-one-to-one scenario. So that patient has to have already had an established physician-patient relationship before that collaborative practice agreement can step into place. And so that is a little bit limiting. There can't be some broad agreement between a healthcare clinic and a pharmacy to say, any patient seen by this clinic can be treated for these types of things. There has to be that established relationship already existing between the specific practitioner and those patients. And so that is where sometimes we see some of the struggle. However, I will note that we have many pharmacists in Kansas that do engage in those collaborative practice agreements, as well as the test and treat protocol and giving immunizations. And of course, I heard COVID-19 mentioned. There are pharmacists that also provide those tests and therapies via the Federal PrEP Act, which has not been codified in Kansas. I would like to note that there is actually a group that called the National Association of Boards of Pharmacy that is a collection of member state boards of pharmacy and actually includes the Canadian provinces as well. And the NABP has a model Pharmacy Practice Act that does actually include this or similar language regarding the pharmacist's scope of practice. And as Dr. Frost noted, that we have seen this to be true in Kansas as well, that these baby steps toward allowing pharmacists to practice in this way have not seen an increase in complaints, investigations, or significant disciplinary action related to them. In fact, if any disciplinary action has occurred, I would note that that has been primarily related to record keeping, which does seem to actually be one of the more frequent violations that we do see in the Kansas Pharmacy Practice Act that the board holds accountable. And on that note, I would like to just reference the question about how would these things come to the attention of the board if there was an issue, and that would only be by complaint. And in fact, certainly we would take any complaint related to a patient care issue or even a complaint from another practitioner, any member of the public, for investigation and potential enforcement action. Ultimately, the board has broader authority than that. The Board of Pharmacy does actually conduct routine inspections of every single licensed facility here in the state of Kansas, and that includes both our pharmacies as well as our other pharmacy-related facilities. And so every year, couple of years, our field staff inspectors who are licensed pharmacists, and I probably should have said at the beginning, I am not a licensed pharmacist, so I cannot answer your practice-related questions, I'm sorry. But our team of licensed pharmacists does actually go out and conduct routine inspections and investigations. They flip through scripts, they talk to the pharmacist in charge at the pharmacy, and they do a pretty deep dive into the operations and to ensure compliance at that facility. So this, if passed by the Kansas Legislature, would become part of that routine inspection as well. And so the board would be looking proactively, not just reactively, at any actions by pharmacists in this regard. One additional thing that I would like to note, I've seen various iterations of the bill and very much appreciate the maker of the bill and the bringers of the bill working with the Board of Pharmacy and receiving feedback and their input. As licensed pharmacists themselves, they do have strong feelings, and as regulators, they understand the importance of getting the legislation right. And so with that, I would just note that we think that it is imperative that there is language that ensures that this provision of law, if passed, would fall under the Kansas Pharmacy Practice Act as a global umbrella to ensure that the board does have the necessary inspection and enforcement authority. The board is ready to take on any necessary regulatory oversight. I would like to address the mystery fiscal note. I apologize because it came off a little bit more cryptic than it was intended. I did provide that information to the Division of Budget, but part of the reason that the board has that position is that while we do not anticipate additional expenses or FTE as a result of this language, ultimately, we do not know what the uptake will be for the pharmacist community in the state of Kansas. That is difficult for us to predict. And so if, this becomes 10% of the pharmacists are practicing in this model, expanding a little bit based on their training and experience, that's certainly something we could absorb within our existing resources. If every single pharmacist in the state of Kansas is utilizing more opportunities through this model, then I think it is possible that many years down the road, certainly beyond the fiscal years that are currently budgeted, the board may need to reassess, just as they do with any new iteration of law and with the growth of the practice of pharmacy in the state of Kansas. With that, I think I've taken up sufficient time, and I'd be happy to stand for questions, Mr. Vice Chair.
Very good. Any questions for Secretary Blassie? Representative McDonald.
Thank you, Mr. Chair. I was wondering if you've done any polling with your pharmacists across the state to see who's interested in this, and I guess that's really my question.
We have not. I don't have any of that information.
Okay, thank you.
Any other questions? Just a quick one. I was wondering how would the pharmacy, is there any idea how the pharmacists who participate would be involved in maintaining medical records sufficiently, electronic medical records, HIPAA compliance? How would all that work out?
Yes, and that would all be addressed in the Pharmacy Practice Act already. And so I think that, again, is why we would just want to ensure, and I'm sure the revisor would know that answer absolutely. I have not had a chance to visit with their office, but that it would fall under that umbrella.
Very good. Representative Oropeza.
Thank you, Mr. Chair, and thank you for your presentation. My question stems from, say the pharmacy is a smaller pharmacy and is only 8 to 5, or they close at 9, and you've had a reaction or something's going on. Is there something that is going to be, they're going to be on call because they prescribed this for the patient? Like, how is that going to be addressed? Because not all healthcare is between 9 to 5.
I think that probably would be best directed to the practitioners that are here. I don't know that I can necessarily answer that question. I would think in the scope of the treatment that communication with the patient would be necessary. A lot of our pharmacists in Kansas do provide after-hours services, whether that's at another location from the chain or an after-hours on-call line, but I can't say for certain. So I would defer that to them.
Okay, thank you. Thank you, Mr. Chair.
Very good. Seeing no other questions, thank you for your testimony. Next, we have a proponent, Dr. Jim Backus, Associate Dean, University of Kansas School of Pharmacy. Welcome to committee.
All right. Thank you, Vice Chair Price and committee members. I appreciate the opportunity to be here today for House Bill 2676. As you said, my name is Jim Backus. I'm an Associate Dean with the School of Pharmacy. I've been with the school since 1998. Prior to that, I was at the University of Nebraska and have practiced since 1991. So House Bill 2676 allows Kansas to use its existing health care workforce more effectively, particularly at a time when many communities, particularly rural communities, underserved communities, face significant barriers. Opponents of this bill will possibly say that pharmacists do not have sufficient clinical experience. However, I would address that concern directly. With the School of Pharmacy, it's a 6-year program, so students usually have 2 years of pre-pharmacy work, oftentimes 4 years of pharmacy work, then pharmacy school itself is 4 years. The School of Pharmacy itself, the 4 years, is 140 credit hours. Over 40 of those, or nearly a third of the credit hours, are clinical experience. So they're working in hospitals, they're working in doctors' clinics, they're working at the medical center, they're working at a rural, critical access hospital. They're working at a mom and pop shop. They're working all over. So that's where they get a lot of these clinical experiences. So pharmacists, as I mentioned, complete a minimum of 6 years, oftentimes 8. About 50% of our graduates now go on and do postgraduate work. So the past couple of years, we've had 50% that have gone on and done residencies or fellowships. So oftentimes, for some of these individuals, it's 10 years worth of training post high school. And I think it's important to point out that these residencies are very medication specific. So they're managing disease states, they're managing diabetes, they're managing high cholesterol, they're managing, these very common conditions. They're giving immunization. So everything they're involved with is medication related. One of the things that we do and we've done for a long time, since the early 2000s, is our first year students, we refer to them as P1s. They come in and they enroll in a national immunization program. So after the first semester, they are certified to immunize. So they've given thousands of immunizations throughout the state. During COVID, we've given thousands of immunizations as well. And so really, very early on, they're getting this experience. The other piece I think that's important about the curriculum is I lectured this morning for 3 hours on diabetes to second-year students. And I give them a fictitious case of Maria, who has type 2 diabetes. She has heart disease. She has high blood pressure. Maria's pretty beat up because, and again, this is fictitious, her husband was in a significant motor vehicle accident. Maria had to pick up a part-time job. With all the stress and all the poor eating and everything, Maria gained 40 pounds, so she has morbid obesity on top of all this. So with these second-year students, their job was to look at Maria and decide what Maria needed. And so they managed her diabetes, they managed her high blood pressure, they managed her cholesterol. They thought about the psychological component of the support that Maria needed, and these are second-year students, along with using other disciplines such as a dietitian to refer them so that Maria could learn to eat healthy. So again, these are second-year students. They have 2 more years in the program, so this information will be reinforced their 3rd year. They'll see actual patients their 4th year. While they're in school, they'll see standardized patient clients, just like Maria, who are acting as someone that has all of these disease states. So all of these competencies that I've talked about are highly supervised. They spend a lot of time in the lab with very seasoned faculty that have done this for a very long time. So what HB 2676 would allow us to do is utilize what these students have been taught. And so that's really the thing, is we're usually the profession that is underutilized, but yet very well educated to do a lot of these things. Today's healthcare is not delivered by a single profession, it's delivered by teams. Pharmacists are the medication experts on those teams, and oftentimes we're the most accessible, and particularly in areas where physician shortages are so acute. So when pharmacists are permitted to practice at the top of their license, patients benefit, access improves, preventative services increase. Physicians can focus their time and expertise on complex cases that require unique training. So I did have the tremendous experience of working in a family medicine clinic in Nebraska back in the 90s. I was embraced with open arms, and they said, these patients are getting complicated, all these medications, we can't keep up with it, so please help us out. And oftentimes they would turn it over to us once we developed that relationship. So it doesn't, expanding the pharmacy scope does not compromise patient safety, as we've heard from data from other states. So Kansas invests substantial public and private resources in educating pharmacists. It's both fiscally responsible and patient-centered to ensure that this training is fully utilized in the service of Kansas communities. Once Kansas limits pharmacists' ability to practice at the level they are educated and trained for, we risk losing both graduates and faculty to states that allow a more modern, team-based approach to care. So HB 2676 reflects the realities of modern healthcare. It aligns education with practice, expands access without sacrificing safety, and ensures that Kansans, regardless of geography, can receive timely care. So with that, I respectfully urge the committee to support HB 2676, and I'd be glad to address any questions.
Thank you, Dr. Bacchus. Representative Weichel.
Thank you, Mr. Chairman, and thank you for being here today. My question is related to the education. Is it accurate that all pharmacists out there practicing have had the education required, or has the education changed over time? So there could be the situation where pharmacists who have been working longer, who are older, who graduated longer ago, don't have the same training as those that are coming out of school more recently?
So education continues to evolve. So yes, there are perhaps individuals that are older than me that we switched over to a doctorate of pharmacy degree many years ago. And that's where this training comes from. So you're talking 25, Kansas, the University of Kansas went all PharmD in 1996, 1997. So you're looking at pharmacists that graduated 30 years ago approximately that may not have that doctorate degree. So.
Thank you. Representative Steens.
Thank you, Mr. Chair, and thank you, Doctor, for being here. I just had a quick question when we were listening to testimony. Do you feel like there's enough safeguards in this bill that it wouldn't lead to, say, misdiagnosing, right? Like somebody may be thinking, okay, I know they have this diagnosis, but maybe something else is going on here. And I'm not saying that all pharmacists would do that. I think pharmacists are very qualified to make lots of decisions, but I'm, just looking at the guardrails here and the language. And then my second follow-up to that, if that's okay, Mr. Chair, is it's a two-part question. Are the pharmacists in the healthcare stabilization fund? Because I just think about this, and if it did open up that, if that would be something that they would, maybe be looking into to make sure that they're covered for liability issues for like that reasoning. Thank you.
So I'll address the second question first and say I'm not familiar with that. I know that most pharmacists, and I can speak for myself, where we do carry liability insurance, Pharmacists Mutual out of Iowa has carried that for a long time. They're the primary carrier for pharmacist insurance. And my understanding, I heard this in conversation the other day, that claims, things such as that have not gone up since the pharmacist's scope of practice has expanded. Regarding diagnosis or misdiagnosis, one of the things that we emphasize is referral, and we've emphasized this for a long time. So for instance, 40 years ago, if you have a pharmacist that has a bachelor's degree, not a doctorate degree, they're talking to a patient that is over the counter and they're addressing a rash. I think most would realize, okay, this looks like a raging rash. This is not something that we should treat with over-the-counter cortisone. This is something you need to go to urgent care for or the emergency room. So I think we're very good at triaging and recognizing that this is beyond our scope and you need to see a physician and be evaluated.
Thank you.
Thank you. Any other questions? Thank you, Dr. Bacchus. Appreciate your testimony. Next on the proponents, we have Tyler Woods from Kansas Pharmacists Association. Welcome to the committee.
Thank you, Vice Chair and members of the committee. Appreciate the time today to provide testimony. My name is Tyler Woods. I'm a pharmacist representing the Kansas Pharmacy Association, where I advocate on behalf of our profession and, more importantly, the patients we serve. I rise today in support of House Bill 2676 because at its core, this is a patient access bill, particularly at what I view or see in rural areas. In many rural communities, pharmacy is the most accessible health care for miles. Some towns, that's the only health care. Not talking just nights and weekends, but just in general. That's a big deal. But despite our doctoral level education, our national board certifications, extensive clinical training, we're regulated as current statutory ceilings that often limit our practice up to what's permitted in rule, rather than the full extent of our education and competency. This bill modernizes that framework, allows pharmacists to provide consistent training, care in their training and clinical judgment. I think that's important. Shifting from a restrictive rule-based ceiling to competency-based and standards. We are trained to deliver a wide range of patient-facing services. Kind of talked a little bit about some of the PrEP Act that demonstrated that, but point-of-care testing, chronic disease state management, preventative care services. These aren't necessarily conveniences. I would argue that these are lifelines for our communities. When we can, as pharmacists, can test, assess, and initiate care within our scope, patients receive earlier treatment. That's fewer delays, fewer unnecessary urgent care, and potentially, if not probably, fewer emergency room visits. It also reduces the burden, as we've kind of heard in testimony already, but the already strained rural physician and hospital systems. Importantly, this bill does not remove oversight or patient safety guardrails. We remain licensed healthcare professionals regulated by the Board of Pharmacy, practicing within those standards of care, those clinical guidelines, and collaborative relationships. From the perspective of pharmacies I represent, the ability to practice at the top of our license and training directly correlates with sustainability. Expanding clinical services not only improves patient outcomes, but does help preserve the healthcare infrastructure in those towns that rely so heavily on it. Members of the committee, House Bill 2676 is a pragmatic, patient-centered workforce, modernization of pharmacy practice in Kansas, leverages an already trained healthcare workforce to close access gaps without requiring new facilities, new workforce pipelines, or taxpayer burden. It simply allows pharmacists to do what we are educated to do and trusted to do, provide timely, accessible care for the patients in front of them. I respectfully ask for the support for this bill. Thank you for the time. Happy to stand for questions.
Thank you very much. Any questions for the House Representative?
Thank you, Mr. Chair, and thank you for your report. You are a practicing pharmacist, correct?
Yes.
Do you see this, if we pass this, being more an advantage to corporate pharmacy where there's multiple pharmacies, say, working in a Walgreens or something? And I'm struggling with a lot of mom and pop pharmacies going out of business. I'm not sure, how this is going to impact them. Can you kind of maybe elaborate on how you feel that might be? I see a little bit of problem with coming in and seeing rotating pharmacists in a corporate situation if you get to be almost like a, quote, patient and not, having different ones.
Yeah, thank you for the question. Just to reiterate, are you saying is there a different advantage or disadvantage for rural pharmacies or non-chain pharmacies? I just want to make sure I'm answering the right question.
Yeah, I said a lot, and you figure it out.
Yeah, fair enough. To be fair, I do think there is, I don't know that I would put an advantage on one community aspect or another, whether it's urban or rural or anywhere in between. I do think there's advantages for pharmacy as the profession to what I would say diversify some of the revenue sources and how they interact with patients in front of them and having the ability and knowledge, but not legal ability to essentially offer the care that we can and should be able to by design, and then therefore can lead to a better sustainability model for pharmacy.
Thank you, Mr. Chair.
Representative Ruiz.
Thank you for your presentation. Can you walk me through the steps? So I come to your pharmacy and I'm complaining that it burns when I urinate. What are all the steps that would be involved?
Sure. The same as you would be in a physician office or an urgent care clinic. The assessment would be made. If there was a CLIA wave test, in this case, there technically is, but a CLIA wave test that can essentially give a positive diagnosis or UTI result, therapy could be initiated. This is also a potential that with the pharmacist's discretion for that patient's specific medical conditions or preconditions and things in that space, it could be a referral off to a physician.
So a follow-up, so there is a test, you're doing a test strip?
Yeah, so
Test,
just like
right.
was mentioned in the CLIA waived, yes.
Right, okay. And so then, looks like I clearly have a UTI, then you could prescribe an antibiotic.
We could initiate therapy at that point, yes, prescribing an antibiotic, yeah.
Okay, thank you.
Representative Bueller.
Thank you, Mr. Chair. Representative Reese was kind of going down the road I was going. I sense a little skepticism from some of my peers in that if you just drew this out on a whiteboard, you'd have the doctor who makes a diagnosis, writes the script, and you give it to the pharmacist, and their only job is to dispense the script, almost like being a bartender. If you want a martini, here's how you make a martini, you give it your client. That's some of the skepticism that I'm kind of hearing, but I'm married to a pharmacist. So I know that when you've got whether it's a minor general self-limiting or one of these other patient emergencies, I'd like you to talk about if you had to write a new script, what does a pharmacist do when they look at, and I know the HIPAA is involved because it's there, but don't you look at the patient's record, what other medications they're on, what drug interactions they have, and don't you advise the doctors when that happens or if you need to, or when a doctor makes a mistake?
Yeah, exactly what you just said, and thank you for the question and comment. The pharmacist's job is essentially to review that patient's full profile, if you will. yes, medications that they're currently on, there are other diagnoses that are maybe listed within their healthcare records. From there, a full assessment would be made. So that's limited or pursuant to the indication of what they're being, the complaint may be, but it can be anything from blood pressure, height, weight, things in that capacity. And then from that standpoint, I think I would like to reiterate that we often, as pharmacists, get calls from physicians saying, hey, I have this patient with this ailment. What would you recommend? So that knowledge and that ability and expertise is there, and on consistently utilized in the healthcare system.
Brief follow-up. So of the 4 conditions where this limited authority would be, and I don't know if it's fair to say, is there one that's most common, or if Kansas were to do this, is there one of these 4 conditions that would be the most likely? Again, I'm not trying to just say,
I will speculate
Okay.
for the purpose of answering the question. I think the most common thing that we see in independent or community pharmacy is out of refills. Okay. And that's not only necessarily limited to patient fault or physician fault or anything to that capacity, but we're out of refills and holidays, weekends, things like that. I think that would probably be the most common of the 4.
Okay, so even the other 4, even though the other 4 are well within the scope of your training and your practice, that one would rise to the top as a number 1.
I think that because it's so correlated with the dispensing aspect, it is so commonly understood and perceived.
Okay, thank you, Mr. Chair.
Thank you, Representative Berquist.
Once again, the smarter people have asked good questions. Thank you very much.
Representative Oropeza.
Thank you, Mr. Chair, and thank you for your presentation. When you talk about refills, are you thinking that you'll refill like immunosuppressive drugs, biologics? Those are pretty...
I think that's a fair question, and I appreciate that. Every instance of a patient interaction, and in this case a refill, would be at the discretion and scope of practice of that pharmacist. I will say in community pharmacy, our most common refills are things within diabetes, hypertension, some of the more prototypical comorbidities and things that we see in the across the state. So, but to answer your question, yes, that's a possibility. I don't know what the commonality is or what the prevalence of that would be, but yes, if that patient's going to suffer by not having that medication, yes.
Okay, thank you. Thank you, Mr. Chair.
Thank you. Representative Berquist.
Thank you. In a personal experience, in my family, we don't go to the medical doctor near as much as some others do, but we do go to the pharmacy and get certain topicals and does this model encourage people to stop going to their doctor?
Thank you for that question. That's a great question. I think it actually does the opposite. I think it opens a conversation at that pharmacy counter with a patient-facing interaction that encourages treatment, and that a referral basis has always been there and will continue to be there. And I think that, if nothing else, it opens the conversation of treatment, care, prevention, early access, things in that space.
Thank you.
Thank you. Any other questions? Just a quick one. Follow up on what Representative Berquist just said about competing basically with physicians. I know a lot of our rural hospitals, rural clinics, they are in trouble partly because of population decline and so forth. If some of their patients start going to the pharmacy rather than the physician office or the hospital, I could see that as being a sort of a competition. But being a problem solver, I guess what I'm thinking is, has it ever been discussed, instead of having a bill where pharmacists basically are starting to practice medicine and going through all the rigmarole of that, why don't I mean, let's use telemedicine, you know, have telemedicine in your pharmacy. Have the patient see the doctor right there. The pharmacy can fill the prescription right there. The physician can discuss with the pharmacist right there, and there's none of the mission creep or turf wars and all this stuff, and it helps the rural hospitals to maintain their patient. I mean, I'm just tossing out an idea on the fly, but any ideas like that?
I think anything that improves access to patient care is a positive. I don't know that there's any singular right answer that will universally or throughout every county of Kansas solve the issues and access problems that we have. This bill's really just focusing on trained and what I would say certified pharmacists to do what they are trained to do. If it's in conjunction with a telepharmacy or telehealth setting, all the better, but that's not always possible everywhere, I guess.
Well, telemedicine's 24/7 in a lot of ways, but I accept that. Thank you very much.
Sure.
Yeah. Any other questions? Yes, Representative Carpenter.
So the Vice Chair brought up an interesting deal that I'd like to flesh out, mission creep. Do you view this as mission creep?
I do not. I do not look at this as mission creep at all. I think it's more of a team creep, if that makes any sense. It's how do we continue putting patients in a better position to get care? And
Thank you for that.
Yeah.
I'm constantly run into this line that people have drawn for, you know, you can't get in my little sandbox type of deal. And I'm getting a little bit upset about this. It's really about access to care and serving our folks. And I just resist that kind of thinking. So thank you.
Any other questions? Seeing none, thank you very much. Any other proponents that would like to speak? I'll draw the committee's attention to 15 or 20 written testimony. We have no neutrals. We have opponents. Rochelle Colombo, Executive Director, Kansas Medical Society. Thank you. Welcome to committee.
Thank you, Mr. Chair, Mr. Vice Chair, members of the committee. I am Rochelle Colombo. I'm the Executive Director of the Kansas Medical Society. And we do appreciate the opportunity, even though we're all alone, to appear before you today in opposition to House Bill 2676. I'd like to begin with just a little bit of background on this issue and how we come before you as opponents today. Just last week, you all heard testimony on House Bill 2157, which would allow for the point-of-care test and treat for COVID-19. And as I mentioned, that was a carryover from Senate Bill 220, and I believe it was 2022. This was the other portion of the bill that was amended out due to conversations and compromise between the Kansas Medical Society and the Pharmacists Association when we raised objections to those two provisions, because at that time in Senate Bill 220, it was this exact premise under the authority of the Board of Pharmacy. This has now been reframed and I would say broadened further to allow for the pharmacist's independent discretion as to what is the appropriate treatment and management of independent states, both with re-prescribing, filling prescriptions, and then these CLIA-waived tests. So it is a significant expansion of the original authority of a pharmacist, and as was expanded just in 2022, and as has been considered just last week by this committee in House Bill 2157. The bill was, I believe, introduced, I don't know when it was introduced, but it was published in the calendar last Friday, which was the first time I became aware of this proposal and the language. But we do have concerns, and I think that they have been firmly established both in historical context around these issues, and I'll talk through them today. They were mentioned by some of the proponents. There are already in law 2 avenues for addressing some of the points that have been brought forward by the proponents, one of those being access to things that are generally self-limiting, which is the protocols that you considered last week in House Bill 2157. The second is through collaborative drug therapy management, which is established in law, and it was mentioned that it is currently a 1-to-1-to-1 ratio. And we have repeatedly said that that is something that can be addressed in law if it needs to be brought into allowed for more authority between a pharmacy and a physician, so that there's more discretion and ability for access and management through what I think we all recognize are highly trained professionals and an incredibly valuable part of the healthcare team. The healthcare team was referenced several times today, and we would agree. In fact, you've heard me testify many times to the importance of a healthcare team, and the team each have different roles. These are different professions. They are regulated differently. They have a different board. They have different authorities. They have different requirements for liability. And yet what they ask for in this bill is some of the same privileges. We think that that's not in the best interest of patients, which you know, and would argue that it's not necessary for access. In fact, if we would like to look at this issue and address some of the concerns we have, we would suggest that there's also a bill being considered right now around remote pharmacies in the Senate. This should not, if this were to pass, should not be allowed through a remote pharmacy. It needs to involve, as has been discussed here, a relationship with the patient. It should not allow for the prescribing of controlled substances. It should actually go through the protocols or through the collaborative drug therapy management, but if that were to be waived, we would ask that controlled substances be limited and not allowed in this bill. Finally, I heard the last proponent say that they would support anything that it increased access and made it easier for patients to get their care they need. What I would tell you right now is it was mentioned that there's a pharmacy, or maybe a pharmacy is the only healthcare provider in many of the towns and places across Kansas. But you cannot get a pharmacy, you cannot get a prescription without an MD, a DO, or an APRN writing that prescription today. So we would suggest that currently there is a restriction in Kansas against physicians dispensing medication. The argument has been made that pharmacists ought to be allowed to practice to the top of their license and that they are trained and qualified to do this. Physicians and APRNs have been allowed by law to prescribe. They are licensed prescribers. Why are we restricting them from dispensing? This would allow patients to get the care they need with a trained professional in diagnosis and in prescribing, and to receive that medication at the same place. There are 45 states right now that allow for physician dispensing. There are restrictions in some of those. Kansas is one that has restrictions. It is limited in that a physician cannot delegate dispensing to an APRN, nor can they dispense in a county that has a pharmacy. And we would request that that restriction be stricken so that there is greater access to the highest top of the license and care for all Kansas patients. And I would be happy to stand for questions, but I would tell you that this is a very significant bill. We haven't had a lot of time to talk. We haven't heard from the Pharmacists Association. We would welcome that discussion, but we think this is significant policy, and there are several avenues which would address access for Kansas patients from a team. And so we are opposed to House Bill 2676, and I'm happy to stand for questions.
Thank you very much. Are there any questions? Oh, Representative Bueller, thank you.
So thank you, Rochelle. I've read your testimony, and I would just say you and I differ vastly on what you've provided to us. I think it's alarming in nature, but I don't really want to go there. So what is KMS doing to address the 250 to 300 physicians that were short in the state? So even if they had, and I would grant you a discussion for another day, if there's a prescriptive authority that the docs need, we can talk about that. But what are we doing to fill that void of 250 to 300 docs? Because until we fix that, we're still going to have the same problem. There's not enough to do this. So when I hear team involves addition and the other players. What you've described in no way adds to that or provides any greater access to care. It's the same little pool. And so I'm really interested, if we're ever going to solve this problem together, how are we going to do it with the same sandboxes just side by side?
I very much appreciate that question, and I'm glad that that you mentioned it and that it was brought up in testimony because there is a physician shortage, and there are many things that we are doing to encourage that. Most specifically, there's a bill that was heard yesterday in House Higher Education Budget, House Bill 2374, which addresses a loan repayment program and encourages Kansas students to relocate in the rural areas. It's highly successful. We have recipients of that program practicing in 89 out of 105 counties in Kansas. There are a number of things that we are doing, but the premise of your question is, that this bill, or that I take it to mean that by passing this, we are addressing a physician's shortage. Allowing a pharmacist to practice medicine does not address the physician's shortage. It lowers the standards. And so we have a fundamental disagreement on that premise.
I think you misunderstood what I said. I said this is a collaborative team. I did not say that it replaces physicians. And I'm happy to hear that KMS is working on it. So when, even with the net migration out of this state, when will we find, how many years will it be, and we can resolve the 250, 300 years, or 300 years maybe, the number of physicians that were short. And I'm not trying to be combative here, but what I'm hearing is kind of the same discussion. It feels like turf protection again. We throw up every obstacle to change, and we're not willing to make partnerships or even concessions. When we do face a real crisis, and there hasn't been any substantive effort to move to the center. And so, and maybe it is just a philosophical difference on this question and others, and I would just say we leave it there.
Well, if I may respond, I think there probably is a philosophical difference, but we are making concessions and we are suggesting several things that would allow for collaboration that we believe are in the best interest of patients. I think our organizations work well together. They have worked hard over the years to find solutions. We have differences, we have philosophical differences, but we are suggesting some things that get to the exact point of what you're saying. If this is about a turf battle, then you know, that's a philosophical difference, and the legislature will make the policy decision which they believes is best. But if it's about access and about allowing people to practice to the top of their license, we should no longer restrict physician dispensing. So there are ways to come to the sandbox together and room for the team to work in the best interest of patients.
Well, thank you, Mr. Chair. I hope that, in fact, does occur. I really do. Thank you.
Thank you. Representative Blex.
Thank you, Mr. Chair. Thank you, Rochelle, for being here. I have a lot of small-town pharmacies with no providers. Certainly, I think I can see some advantages for them to be able to treat some minor things that come in and on a somewhat more personal basis than maybe going online or teledoc or something. Or, you know, and we're seeing a lot of regulations by hospitals. If they do send a person over, they tell the patient, well, you've got to get this prescription filled at 35, 40 miles away, which is cumbersome to particularly a person who doesn't drive well or older. And I have to, Representative Bueller's comments on turf battles, I've seen a lot of these, and I guess and I would like to see a little more collaboration. I kind of understand why we have so many boards. They're kind of the specialists and anything, but things are changing. The patient accessibility is really diminishing, particularly in my rural areas, to adequate providers. And I appreciate, again, your standing up for patient safety, but would you feel the same way if the pharmacist was under the Kansas Board of Healing Arts?
I appreciate your question. I mean, they are asking for privileges that would be regulated under a different board, although I didn't suggest that in our testimony. I think that the pharmacy board appropriately regulates pharmacy. This does allow for prescriptive authority, which is something different. So I think there's a lot of room for collaboration, and there is a lot of ways that are being developed for access, including telemedicine and different restrictions around that, which open the door to access as well.
Thank you.
Representative Berquist.
Yes, thank you, Mr. Chair. I'll try to keep this short. Thank you, Rochelle. And through the years, I've been on the committee for a little over 8 years. And we've gone through a number of different iterations of trying to find models to increase healthcare access to Kansans, because that's the people we're responsible for. And I think about triage situation rather than turf war. Triage situation says that we're in an increasing shortage of some healthcare workers, including doctors and nurses and almost every field. And so when we look at these things to try to meet that, it's not trying to, I don't think in general we're trying to diminish the quality. We're trying triaging the situation on the ground that says there's fewer and fewer people that are having access to health care and eventually maybe become sick and die because of it. So for those reasons, we're trying to explore these things, and there seems to be sometimes a brick wall that says, yeah, but that you can't go past this because that's the way we are established. We're just saying that we, as a committee, that we need to establish open dialogue that says, this is the situation we're in now, or this is the situation we're in next year. And because we want to see people have health care and we want to see people live long lives. And I appreciate the conversations and 2 or 3 of the things that are going about right now in our committee. And this is just one of them. I want to thank you for being part of the conversation. And sometimes we clash, but we're having a conversation. Thank you.
Thank you. If I may respond to that, I just want to say we agree with that. I mean, there is a shared value, I think, here between all the members of the committee and the Kansas Medical Society, which is making sure that Kansans have access to high quality care. And I'm not here to say that I don't think that we absolutely believe pharmacists are a valuable member of the healthcare team. They are highly trained. These are very competent people. There is no disrespect for this field or the other providers of the healthcare team. What our position is, if I haven't been clear, is that when privileges are granted that allow for people to enter into those other aspects of medicine, whether it's prescribing or diagnosing or performing procedures, that we believe that it's in the best interest of Kansas patients. Access is important, but so is maintaining the same standards, the same requirements. And so among those would be things like training and education. They've made a very good case for their training and education, but also liability requirements. And not just for them to say that we carry it, but that the law stipulates that they carry a mandatory level of appropriate insurance and that they participate in the Healthcare Stabilization Fund. Those are the reasons that we oppose some of these bills, particularly this one, is it doesn't address those. It doesn't put the same protections into place that are required of other people. So it's not that other folks can't practice competently, it's that the same rules should apply.
Thank you, Mr. Chair, and I did not mean to detract from this specific subject, but in general, thank you.
Thank you very much. Is it Representative Droege? Yes.
I just had a question, maybe a clarification, and thank you for the opportunity. My hometown pharmacist, and I have pharmacists in my family, great friends that are pharmacists, but they seem to have this collaborative relationship with the doctors, their first name basis, their speed dial on their phones, and my local pharmacist says, man, I have no reason to need this. I can pick up the phone and reach any doctor instantly, or if they're able to be reached. Am I wrong on that? Isn't it collaborative to the point that they can get that kind of access?
Would you like me to answer? That is exactly how collaborative drug therapy management works. And that's a very good example, and I think that is how it's handled, particularly likely in a lot of independent pharmacies and in smaller areas where the communities are more well-known to each other. And we would suggest that if that process isn't working as well as it should in some of the urban areas, that's something that could easily be addressed in the law. But it is working in many of the rural areas. But I would, I'm sure the proponents would have something different to say about that, but that's certainly been our experience. And the way that the protocols were developed involve a lot of the folks who serve in those kinds of relationships and work through collaborative drug therapy management now. So thank you for your question.
Thank you very much. Thank you for your testimony. And committee, that ends our hearing on House Bill 2676. Let me just say, I did use the term mission creep earlier. I want to apologize. I should have said increase in scope of practice, and I'll try to be more respectful as a chair. So the next hearing will be House Bill 2702. Reviser will give us an update. Thank you.
Thank you for that.
Poor choice of words.
Thank you, Mr. Chair. Committee House Bill 2702, as introduced, provides that applicants for a physician assistant license submit to a criminal record check, provides for the collaboration between physicians and physician assistants, and requires the revocation of a physician assistant license under certain circumstances. Section 1 provides that, under certain circumstances, the State Board of Healing Arts may require an applicant for a physician assistant license to submit to a state and national criminal history record check. Section 2 amends KSA 2247-14, which allows a governmental agency to require a person to be fingerprinted and such fingerprints be submitted to the KBI for the purposes of a criminal history check, to add the State Board of Healing Arts for applicants or licensees of a physician assistant license. Section 3 amends KSA 65, excuse me. Section 3 amends KSA 65-28-127 to set out the requirements of a collaborating, supervising, or responsible licensee. Section 4 amends KSA 65-28-01 to add physician associate to the name of the Physician Assistant Licensure Act. Section 5 amends KSA 65-28-02. Which are definitions used throughout the Physician Assistant and Physician Associate Licensure Act. New terms include collaboration, collaborating physician, licensee, license, healthcare services, practice agreement, supervision, and supervising physician. Section 6 amends KSA 65-28-A03 to include a reference to KSA 65-28-A07 after the mention of a temporary license. Section 7 amends KSA 65-28-04 to state that the Board of Healing Arts may grant a physician assistant license to an applicant who has submitted an application, paid the appropriate fees, completed the required educational program, passed the national certifying examination, does not have a license currently under discipline, suspension, or probation, and submitted to the State Board any other information the Board deems necessary. The Board may also grant a license to an applicant who does not meet the required educational program, but who prior to 1986 passed the national certifying examination and submits proof to the Board that such applicant has acquired experience while serving in the Armed Forces of the United States. Section 8 amends KSA 65-28-A05 to provide that a licensee's license may be revoked or suspended if a licensee has been convicted of a felony, Class A misdemeanor, or a substantially similar offense in Kansas or another jurisdiction. Section 9 amends KSA 28-A06 to allow a person who meets the qualifications for licensure but does not possess a current license to use the title of PA, physician assistant, or physician associate, but shall not practice unless licensed. Section 10 amends KSA 65-28-08 to provide that a physician assistant may provide healthcare services within the education, training, and competence of the physician assistant. The section also lists healthcare services a physician assistant may provide, including obtaining and performing a comprehensive health history and physical examination, evaluating, diagnosing, managing, and providing medical treatment, and ordering and evaluating a diagnostic study and therapeutic procedure. Subsection B provides that a physician assistant may prescribe durable medical devices and medical equipment, prescribe, procure, and administer drugs. Subsection B6 sets out the requirements of a prescribing physician assistant, including complying with all state and federal regulations and prescribing shall occur when pharmacy services are not reasonably available, when it is in the best interest of the patient, and in an emergency. Subsection H provides that a physician assistant who attests to having 4,000 hours or more of postgraduate clinical experience and does not have any disciplinary action against their license can practice in collaboration with a physician or physician group pursuant to a practice agreement kept on file at the practice site. Subsection J allows a physician assistant with less than 4,000 hours of clinical experience to practice with a physician supervision under a written practice agreement. Section 11 amends KSA 65-28-09 to provide that a physician assistant with a supervision practice agreement shall not perform healthcare services unless the name, address, and signature of each supervising physician on such agreement has been provided to the board. Section 12 amends KSA 65-28-A11 to include a physician in a practice agreement with a physician assistant to the Physician Assistant Council. House Bill 2702, as introduced, would become effective on January 1st, 2027.
Thank you, Carly. That's a mouthful. Any questions for the reviser? Representative McDonald.
I guess it's just a process question, but we don't have a bill brief, and so it's really hard to follow, especially one that long. Is it possible that we could get a copy?
Mr. Chair, I believe so.
Okay, Representative Ruiz.
The practice agreement, there's different words that are used. Practice agreement, collaborative agreement, am I correct in that? With a collaborating physician?
Yes, I believe they are different terms used for different kinds of agreement entered into between a physician assistant and a physician.
Okay. Do we know what the content of those agreements are?
Mr. Chair, Representative, I do not, but maybe a conferee could answer that question for you.
Okay, thank you.
Any other questions? Seeing none, thank you, Carly. The first proponent for the bill will be Kirsten Stevens, Kansas Academy Family of Physician Associates, excuse me. And I believe she will be virtual. Welcome to committee.
Thank you, and good afternoon, Mr. Chairman, Mr. Vice Chair, and members of the committee. I really want to thank you for the opportunity to speak today. I am speaking on behalf of the Kansas Academy of Physician Associates in strong support of House Bill 2702, which amends the Physician Assistant Licensure Act. Current statute in Kansas was first adopted in the 1970s, and it defines physician assistant practice as medical services delegated by a supervising physician. While this model served an important purpose historically, it no longer reflects how healthcare is delivered today. We've been talking a lot about team-based models. So we know that these models improve patient access, strengthen healthcare workforce, and maintain high standards of safety and quality. Healthcare delivery has evolved significantly. Plus, demographic shifts along with workforce shortages make collaborative, team-based care more important than ever. House Bill 2702 adds collaborative practice terminology, appropriately recognizing PAs as integral members of a physician-led team. Before discussing specific provisions of the bill, I want to take a moment to thank the Kansas Medical Society for their willingness to engage in thoughtful and productive discussions. This legislation is a result of more than 2 years of research, careful review, and meaningful dialogue. I also want to emphasize one very important point, that this legislation does not expand or restrict scope of practice for PAs. This is not a scope bill. Instead, it reflects best practices and supports more efficient healthcare delivery with improved patient access to care. I have provided a section-by-section summary for your review, but I would like to briefly highlight several key provisions. Sections 1 and 2 address the fingerprinting authority, and this is important because the PA licensure compact was enacted in Kansas in 2025. And so this provision helps us meet the requirements of the PA Licensure Compact Commission. Section 4 ensures that PAs licensed under either professional title, physician associates and physician assistants, remains clearly covered under the Practice Act. This keeps Kansas law aligned with how the profession is defined, taught, and represented nationally, now and in the future. Of note, we have both physician associate and physician assistant programs in Kansas. Section 5 defines collaboration as consultation with or referral to the appropriate healthcare team member based on the patient's condition, the PA's education, experience, and competence, and the applicable standard of care. Collaboration is implemented through structured practice agreements, team processes, and communication. Section 6 removes the requirement that the board approve every individual physician-PA practice relationship. Again, healthcare delivery has changed dramatically. Many physicians now work within large healthcare systems rather than private practices. And, this ends up providing more opportunity for mobility. And then we've been talking about workforce shortages, and these shortages often then require temporary coverage arrangements. Under current law, a physician assistant needs to submit new paperwork every time a supervising physician changes. This creates unnecessary administrative burden for not only providers, but also clinics, hospitals, and credentialing staff, all without really improving patient safety. You do have some written testimony supporting the fact that this is a barrier in clinical practice. And so that testimony will address this barrier. The provision in House Bill 2702 makes the process less onerous while maintaining appropriate oversight. Section 10. This clarifies that a PA's scope of practice is determined by their education, training, and credentialing, not by attachment to one specific position. This bill proposes the bill proposes transitioning experienced PAs to collaborative practice after completing at least 4,000 hours of postgraduate clinical experience, allowing the level of collaboration to be determined through practice agreements involving the physician or physician group, the PA, and the healthcare facility credentialing system. Maintaining physician supervision or having a supervisory practice agreement for PAs with fewer than 4,000 clinical hours. And this would still be consistent with current law. I want to take a moment here to just emphasize the fact that this transition to collaborative practice after 4,000 hours is optional. There may be some practices in Kansas that having the supervisory practice agreement in place is the best for that practice or that PA physician relationship. So it just provides an option for more experienced PAs. The provision also allows experienced PAs in a collaborative agreement to deliver uninterrupted patient care for up to 180 days after the loss of a collaborative physician, with a possible one-time board-approved extension. And this becomes important because there are some PAs, for instance, that work in rural clinics. And if there's an unfortunate occurrence and they lose their supervising physician, then that clinic or practice is just simply closed. The PA cannot see patients, even if they've been seeing them for many, many years and been, maybe known by their patients as like a primary care provider. They can't continue that care. So we feel this is appropriate, especially in rural settings, and with board approval would then improve continuity of care for Kansas patients in rural or underserved communities. And this still maintains appropriate involvement and regulatory safeguards. The PA, for instance, would still have a network of physicians and providers if needed. We respectfully request consideration of two small clarifying amendments within Section 10. First, on page 19, line 37, we propose adding the phrase, including prescribing drugs, to clarify that prescribing is included within healthcare services described in the practice agreement. Second, on page 21, line 42, we propose replacing the comma at the end of the line with the word or. This clarifies who may develop the practice agreement. This change ensures consistency within statute and reflects real-world healthcare team structures. In closing, House Bill 2702 updates Kansas's physician assistant licensure framework to reflect modern healthcare delivery. It preserves physician leadership while empowering PAs to function as integrated members of healthcare teams. Most importantly, though, it improves access, efficiency, and continuity of care for Kansas patients. The Kansas Academy of Physician Associates respectfully urges the committee to support House Bill 2702. Thank you for your time and consideration, and I would be happy to stand for questions.
Thank you, Ms. Stevens. Are there, in the interest of time, we can keep the questions short. Are there any questions for the conferee? Seeing none, thank you for your testimony. Next on the proponents, we have Rochelle Colombo, Kansas Medical Society. Welcome again to committee.
Thank you, Mr. Chair, members of the committee. I'm Rochelle Colombo, Executive Director of the Kansas Medical Society. I will be very brief today in the interest of time, although I would love to spend a lot of time talking about this. We are very strongly supportive of House Bill 2702 and also would like to echo the comments of Ms. Stevens. Very appreciative of the opportunity to work with the Kansas Academy of Physician Associates. Though we worked and labored over the language in this, it was introduced last year or attempted to be, but because of time constraints, it wasn't able to come through the process last year. But it is an update into current law where most of the Physician Associate Practice Act was dealt with through rule and regulation. This brings more of that into the statutory framework, is very clear. It preserves the distinction, as Ms. Stevens said between physicians and other members of the healthcare team, but does allow more flexibility, which creates more access and a better operating environment for the healthcare team. So I know everybody's got other committees to go. We would be happy to answer questions, but it has been a very thorough process. We do support the 2 amendments that they requested and think this is an excellent piece of legislation and would urge your support.
Thank you. Are there any questions for Ms. Colombo? Seeing none, thank you. Oh, here's Representative Carpenter for a question.
No question, just a statement. I appreciate you guys working together in this a collaborative way to come before us with no arguments. Everything's already worked out. It's a breath of fresh air for my year, so thank you for that.
Thank you. We're very appreciative of the Academy for coming to us and allowing us that opportunity.
Thank you. In the interest of time, we will forego final action on the last item on our agenda, House Bill. Oh, I'm sorry. We're still on the bill. I'll draw your attention to written testimony. Neutral testimony is Susan Gile, Executive Director, Kansas State Board of Healing. Ms. Gile. Jump the gun.
Good afternoon, Chair and Committee. Excuse me. My name is Susan Gile. I'm the Executive Director of the Kansas State Board of Healing Arts. I will also be brief. You have my neutral testimony. And really what I want to do is walk back some of the concerns that were outlined in my testimony. I did have the opportunity yesterday to speak with Doug Smith of the Kansas Academy of Physician Assistants or Physician Associates, and he was able to explain a lot of what was provided, the testimony that was provided to you here today. And with that information, I feel like the board is much more comfortable with the language in the bill. So I just wanted to let you know that we are more comfortable after that conversation. Some of our concerns, as you can see, were with the loose definition of collaboration versus the practice agreement and the supervising physician, and not being clear on who was who and when which would be used. And he graciously explained all of that. And so I think that I'm much more comfortable with that. So with that, I would stand for questions.
Representative Carpenter.
Thank you, Mr. Chair. So would that be a proponent then versus much more comfortable?
I have not had the opportunity to speak with my board, and my board did direct me to stand neutral on this, so I am not able to change the actual qualification of the testimony, so I'm going to have to stay neutral for the board. But after that conversation, I think that I would walk back some of those concerns.
Very good. Thank you.
Thank you.
Thank you. Are there any other people here who want to testify? Seeing none, we will close the hearing on House Bill 2702. Mr. Chairman, do you have a comment?
We will put off final action on 2520 until tomorrow. We'll amend the agenda. We'll do that first thing tomorrow. So, yes.
Very good. We are adjourned.